Hello and welcome to the Headache Doctor podcast, where on this podcast, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. In today's podcast, we are going to revisit the most overlooked cause of headaches and migraines. The reason we're doing this is because I know that we have a lot of new listeners that have hopped onto the podcast since we last did this episode. I last did this episode in March of this year. So we are overdue. It's time to talk about the most overlooked cause of headaches and migraines. Now, if you are someone that's interacted with us, maybe you called because you were interested or you have started our process, you've probably heard this episode because we typically send it out to anyone who we can get a hold of, who we know. If we want to just simplify our process, what we do, and why you would need it, this podcast episode is the best way to do that, because what I'm going to do is address our current healthcare system and why your issue, the underlying problem that's overlooked, that's led you down this cycle of searching for relief and getting medication and feeling stuck in this trap and leading to basically hopelessness. I'm going to talk about why that's the case. This podcast is generally our most downloaded podcast episode, and that's because it really provides answers, and then people, once they listen to it, things start to click and they understand, okay, this could be me. There could be something here. I hope there's some aha moments for you listening if this is the first time you've heard me talk about the most overlooked cause of headaches and migraines. Oftentimes on this podcast, we talk about all types of different things that are helpful, that are kind of tertiary to this core subject or secondary to this core subject of the overlooked cause. But this is the bread and butter of what we do. If you are new to this podcast, I'm Dr. Taves, your host. I'm the founder and one of the headache specialists here at Novera Headache Center. We have locations in Colorado Springs and Parker. The mission of this podcast, like I said at the beginning, is to educate and empower everyone with headaches and migraines, and specifically to break free from fear of your next headache or migraine and dependence on medication. Those two things are very pivotal to what we are about here at Novera Headache Center. And it's really hard on the internet to find anything that's not leading you down a road of medication. And so we're trying to be that beacon of hope in what seems like a pretty hopeless world when you have headaches or migraines. So what I want to start out with is just defining your interaction with the healthcare system and why it seems like these really brilliant, bright, well-trained physicians, neurologists are unable to provide you with a solution. So I'll start off by giving a snapshot of my story. So I am a physical therapist. I trained at the Mayo Clinic, and I graduated about 10 years ago. I was very interested in the neck, jaw, the shoulders, and specifically manual therapy, which means hands-on treatment. I was mentored by a few very good physical therapists, one of them specifically out in Minnesota, and I learned how to treat the neck. I started practice and was treating patients with headaches, jaw symptoms, shoulder issues, really all sorts of things. And I remember about 6 months in, I had my first migraine case. So this is someone who had been clinically diagnosed with the diagnosis of migraine. She had seen 3 or 4 different neurologists and felt like she just didn't want to keep taking medication. The medication wasn't working. She was too reliant on it. And she didn't get referred to us for her migraine. She basically just found us, I believe, and it was sort of I have this neck issue, and I'm not sure if it's related to my migraines. And at the time, I thought, the migraine is something that the neurologist needs to take care of, but we can work on your neck. What was interesting, though, is she kind of intuitively knew, okay, I think my neck is involved here, and the medication and the neurology visits haven't helped. And so what happened is we treated her neck, long story short, and her migraines essentially went away. Months and months went by, and she was like, I'm good, and she just kept being good. The migraines basically vanished, okay? Now, fast forward 6 to 12 months, something like that. I had seen a few dozen people in that same category, like diagnosed migraine symptoms. Some people are like, oh, that's not really a migraine. I'm telling you, these multiple neurologists diagnosing this as migraine, all the classic symptoms, they were debilitating. So like there's not a scenario where it's like I'm just capturing people with neck problems that think it's migraine and the migraine's something separate. The reason this was so profound is because these were migraines, and they had been diagnosed as migraines by multiple physicians. These patients had symptoms that match exactly with the symptoms of what the International Classification of Headache Disorders would describe as a migraine. Like there was really no way around it. Like these were migraines, and they were treated effectively by working on the neck. Okay, so now I'm in this dilemma. Is this a fluke or is this a real thing? And if it's a real thing, then there's opportunity here that feels like a little bit confusing. Like how do so many people suffer from headaches and migraines? And then we get to this point where I'm basically a year out of school and I'm treating these people's necks, and basically all of them are finding the relief that they've never found through our healthcare system. It's very confusing. And so what I did was I looked into the research. It's 2025. There's no secrets anymore. Everything's on the internet. And that's true for journals and randomized controlled trials and things that guide clinical practice. And so in our Western medicine model, the term evidence-based is kind of pounded into you as a physical therapist or medical student. And so everything is sort of guided back to, okay, what does the evidence say? And so when I looked at what evidence these neurologists were using to guide their clinical practice, really the studies were a little bit cyclical, right? So oftentimes what would happen is they would stumble on some medication that was sort of being used as like an off-label prescription for migraine. So maybe it was like a heart medication or an anti-anxiety medication, but they found that it had some benefit for migraines. And then what was happening was that they were using that medication to validate what they would assume is happening with the migraines. So they would get to the point where they'd say, okay, this is vascular, or this is neurological, or this is something with serotonin. And those medications were really just manipulating the symptoms. So they were changing the perception of pain. They weren't necessarily addressing the underlying source. And there were all these different medications, and each one of them, again, was just masking symptoms. Like there was no understanding of why this was happening, why the severe pain and all these weird symptoms, where they were coming from. And so, I mean, Johns Hopkins, Mayo Clinic, Cleveland Clinic, like Diamond Headache Center, like it doesn't matter. They don't necessarily know why. Like if you ask a question why, you likely will not hear a response. Like they'll say, we don't really know, but we do know XYZ. And there's sort of this weird dynamic where they'll have like no confidence in understanding why. They'll be like, we don't know why. But then they'll have like 100% confidence. This is just a little tangent. But they'll have like a lot of confidence that it's like not from the neck. It's like, well, we don't know what's causing it, but we know that the neck is just a side effect and your migraine's causing your neck to hurt. Anyways, I just don't understand that dynamic. Like, how do you have it both ways? How can you not know what's happening, but like know that that's not what's happening? Anyway, we're going to get into that a little bit later. So I dig into the research and understand that neurologists are really just using symptom management in their approach, and they don't understand the underlying cause. Okay. Now, those two things, these two things are now reality in my life. I've been helping dozens of people with clinically diagnosed migraine, and they have been finding relief like they've never found before. Many of them, like basically their migraines are gone. And our current healthcare system doesn't know why these migraines are happening, and they're really just using a symptom-based approach, meaning medication. Okay? So if we put those things together, it's like, okay, I have now an understanding of where these symptoms are coming from. And you might be thinking, well, like, wouldn't our healthcare system have found that? Not necessarily. And here's where it gets complicated and interesting. The medical doctors are trained, and it's very heavy they're heavily trained in pharmaceutical symptom management when it comes to understanding biomechanics, function, mobility, and even just like pain generated through joints, muscles, tissues, tendons. It's pretty limited. And so when it comes to trusting, like a neurologist, they're trained in understanding the brain and how the brain works. And so they will have a good understanding of like pain signals and how pain is transmitted, and whether it's like manipulating serotonin or the CGRP receptors or things like that. But when it comes to understanding biomechanically what would originally send a pain signal, they would rely heavily on like an X-ray, an MRI, something like that. So still images, there's really not a realm or an avenue where you go down our traditional healthcare system and a medical doctor is evaluating your neck appropriately, meaning like looking at how it functions. Our neck is very dynamic. There's a lot going on. It's a very simplified evaluation. So essentially they're missing like large components of neck dysfunction that generate pain. What's also true is that it's well documented that the neck, the upper cervical spine, so anywhere from the base of the skull to C3, can refer pain into the head or the face. And it's even documented that it can cause like light and sound sensitivity, visual disturbances, like all of these things that encompass a migraine. And so it's called a cervicogenic headache, essentially. And so there's a thing called a cervicogenic headache, and then there's the migraine, and they're two separate categories. A migraine, I think it's like 80% of people with a migraine present with neck pain that coincides with the migraine. But almost, I think by and large, our healthcare system accepts that reality and says, oh, that's the migraine causing the neck to hurt because of this connection. So they're basically acknowledging the referral pattern and this connection, this pathway that can sensitize, one area can sensitize the other, but they're like so closely tied to the migraine being a thing in itself that the only way to hold on to that philosophy is to say that the neck is secondary. That's a symptom of the migraine itself. But then you say, well, what's the migraine? They say, we don't know. But it's so interesting because the reason they're able to say that the neck pain is caused by the migraine is because of this pain pathway, okay? And so when you think about, okay, there's a pain pathway, and the brain basically is taking head pain, and maybe it's thinking it's neck pain, or it's taking neck pain and it's referring it to the head, okay? So then it's like, well, it's chicken or the egg, right? And so to understand which one is the actual source, you have to get really good at evaluating both, right? So this is like a logical way of thinking through this. Now, we are assuming that our evaluation of the neck is like spot on. We're not missing a thing, right? That's what we're assuming. In our healthcare system, when it comes to the brain itself, the brain doesn't actually have pain receptors, the dura, which surrounds the brain, the blood vessels that surround the brain. There are things that surround the brain that when they feel pressure, when there's inflammation, they can be sensitized. The brain itself doesn't actually feel pain, which is kind of interesting, right? Like they can do brain surgery on someone without anesthesia or they don't have to put you under general anesthesia because the brain doesn't actually feel pain. It's fascinating. Okay. So the brain itself, it feels like your brain's hurting. It feels like your brain's going to explode, whatever your symptoms are, stabbing. But the brain itself doesn't actually feel pain. So it doesn't make sense for the brain to necessarily be the problem itself, right? And then we think of the structures that surround the brain. So whether it's that dura or the blood vessels, like those things, if they're inflamed or there's pressure, then those things can experience pain. And that's where like tumors and brain bleeds and stuff like that. And our healthcare system is super good at catching that stuff. Our imaging's really good at it. Like it's getting more and more detailed. Our technology's more advanced, and we can catch that stuff like really early on. So that's not something that we necessarily need to worry about being missed. Now, when we think about the neck, there's a lot that can be missed in our understanding of the neck, okay? Because there's so much movement that happens in our neck. Our neck is very mobile. And if we're relying on those same images that we use to screen the head and the brain to screen the neck, basically all we're potentially going to find is just some like wear and tear to the mid portion of the neck, like C3, 4, 4, 5 has some degenerative disc disease and stenosis or something like that. And that's basically it. But the thing is, C3, 4 and 4, 5 and 5, 6, they don't refer pain into the head. That's C0, so basically the base of the skull to C3, okay? And so if it's not high up, which it almost never, there's almost never going to be an issue high up. There are things that happen on imaging that can be seen, but like I said, it's very, very rare that we have someone come in that had some change up high. The mid portion of the neck takes on most of the stress when the neck is dysfunctional, and that's why these patients are seeing the mid neck wear down, and then they see that on imaging. But it's still it's a still image. So we're not evaluating movement, and even if you go outside of the Western medicine model and say you try chiropractic or acupuncture, it's still not looking at it and addressing movement. So there's still this gap in our healthcare system where no one is looking at and restoring function to the neck. And then you say, okay, well, physical therapists, like they're kind of the movement experts. Well, historically, physical therapists have really been a service that the medical doctor can prescribe. And it's oftentimes been the orthopedic surgeon in the outpatient setting. It's been the orthopedic surgeon that's sort of dictating like exactly what the physical therapist should do. We're moving away from this. Physical therapists generally are autonomous, but still largely dictated by insurance. Insurance will say, well, you have to get a physician referral. That physician, you want to keep them happy. So these in-network practices try very hard to do what the physician wants. And because the migraine world is so closely like our healthcare system is really, really like not wanting to budge on this idea that a migraine is a spontaneous neurological event. They have a tight hold on that. And so for a physical therapist to start saying like, hey, we can treat this, it's challenging, just naturally how the system's set up. Now, that's assuming physical therapists knew how to treat this, when by and large, it's very challenging to find a physical therapist that has any level of confidence or has helped someone with headaches, but let alone with a migraine. And most, even the really good ones, where I've gone to their courses, they're going around the country teaching on neck stuff, they will say, like, a migraine is different. Like, we don't, like, a migraine is for the neurologist, the migraine requires medication. I've heard it a bunch, okay? And so there's just like this cyclical pattern that means like if you have a migraine, you're just sort of stuck. Like there's no help. It's just medication. And if you ever think it's your neck, that's just a symptom and don't think otherwise. But also don't ask me what a migraine is. Like it's a very weird dynamic. So that's the system we're in. Now, what is the most overlooked cause of headaches and migraines? It's that movement that we're missing. Now, as a physical therapist, we basically want to just look at the neck and understand how should it be functioning and what dysfunction would cause pain or irritation that's then sending a pain signal into the head, and then you're experiencing eye pain, temple pain, light and sound sensitivity, nausea, vomiting, brain fog, okay? So basically what's happening is the head sits on the first bone, called the atlas, and then you have the atlas that sits on the axis, which is like a thumb-like structure. The first bone, the atlas, sits on that axis and it rotates. It does about half of our rotation, think like 45 degrees. So when you turn left, turn right, half of our rotation comes from C1 and C2. And then we have C2, 3, which is also fair game. There's some movement there. It shares about, I don't know, like the rest of the neck does about half of the rotation, the other half of rotation. And so let's say like 5 degrees and in multiple planes of movement at C2, 3. And then you've got the head sitting on the first bone, the axis or the atlas, and it does this nodding motion. And so it does nodding, it does a little side to side. The atlas should shift left and right just a little bit. And so we've got this head that weighs 10 to 12 pounds, and it's on a very mobile upper part of the neck. And when we understand the weight and the amount of stress on the neck, and then it can either be a sedentary lifestyle, whiplash injuries, maybe you were an athlete, maybe you were a dancer as a kid, maybe you just jumped on the trampoline and tried too many backflips. Like there's a gazillion reasons It's kind of like cavities. Like if you ask the dentist, like, well, why do I have a cavity? It's like, I don't know specifically why you have a cavity, but there's like a gazillion reasons why your dental health and your pH in your mouth and the enamel would have worn down. It's not necessarily one thing. There are some people that have like, a severe trauma that, it's like, okay, most of your neck problem is from this. But then we have people that are like, I've never done anything to my neck in my life, and I have severe migraines. So this podcast isn't necessarily for that, like understanding all the different reasons why, meaning this podcast episode. It's not designed to go over all the different reasons why, but understand that there's a lot of different reasons why the neck would have a level of stress or tension and be dysfunctional. Any area of the body that has more mobility is generally sacrificing stability. The more stable a joint, the less likely it is for injury. And so when we have the upper part of the neck that's really mobile, we associate that with higher chance of injury. And then especially when we have someone that's hypermobile, so females are generally more mobile than males, and migraines are 2 to 3 times more likely to pop up in females. There's other reasons for that increase in likelihood, but this is one of them. The mobility that you're dealing with is elevated, and so you're also at elevated risk of injury. And then we have the 10 to 12 pound head. It's like carrying around a bowling ball. So basically our necks get really stressed out, and we can't see how stressed they are by just taking a still image. We have to see, okay, like, I mean, it's amazing. We will literally just press on different spots of the upper cervical spine. After people have tried, a dozen different providers, suffered with this for 20 years, and we'll literally just lay them down and push on some different spots to test, one, the mobility, but also the sensitivity level in like muscles, the tissues around these joints, and the joint itself. And it, like, not a ton of pressure, and it'll reproduce their headache. And Dr. Romero has a really good analogy. He says it's like finding the remote. Like, we need to find the remote, and when we find it, it'll turn the TV on, right? And it's not a scary thing to find the remote. We just need to know what's controlling your pain. And just like a remote in a TV, like you find the remote, you click the button, the TV is not where the remote is. It's, it's on the other side of the room on the wall, but it controls it, right? Ultimately, the remote is what we need to find so that we can either turn on and shut off. Obviously, we don't want to turn on the pain, but we know that it's controlling it, so we can shut it off, turn it down, turn down the volume, right? And so in our process, when we find that the neck is dysfunctional and we see that these movements are lost, like it doesn't rotate, it doesn't nod, it doesn't side bend like it should, and it likely hasn't for years or decades, then we can put a little pressure there. It's like, oh, yep, that's my pain. Like, that's the pain behind my eye. That's the pain in my temple. That feels really sensitive. Then we know, okay, this is the area that we need to address, because this is actually what's sending the pain into the head. Okay. Now that might seem like, wow, that's like overly simple. And how can I, go through my whole, my adulthood life and not have, been told this or met a provider that can do this? I mean, yeah, I'm right there with you. Like, it's crazy, but it really is. It's that simple, but it's not easy. This isn't an easy process to get out of. And what I mean is, there's lifestyle change involved. There's work in order to restore the upper neck back to how it should function. So we use a lot of hands-on techniques to put pressure through those joints to get them moving again. I use the analogy of someone who has, like when you hold your phone up to your ear and your elbow's bent, and then after about 10, 15 minutes, you realize you need to straighten it out. Your elbow gets sore. The reason it gets sore is because our body wants to move, and when we don't move, the joints get angry. And so when you straighten it out, everything starts to feel better. Well, imagine if you just had your elbow bent for like 10 years. After like a few weeks, months, it would probably start to adapt to that shortened position. I mean, the ligaments, the muscles, even the skin would adaptively shorten to the lack of mobility, right? So the longer it's gone on, the stiffer it's going to be. But essentially, when you're trying to treat something like an elbow that won't extend, I mean, yeah, the muscle's going to hurt around it. The joint itself is going to hurt. So think of it this way. if your elbow doesn't extend, and you go into if you go into a primary care doctor office or a neurologist, right? They'll say, okay, your elbow hurts, take ibuprofen, or then they'll take, in the case of a headache, it would be like Excedrin or whatever pain medication, right? Sumatriptan, Emgality, Ajovy, and it would all be medication based. It'd be like, all right, take this medication to see if you can calm the inflammation down, and we'll treat the pain itself, right? So that would be the MD approach. If you went to a chiropractor and you said, hey, my elbow doesn't straighten out and it hurts a lot, they do a technique to like cavitate, get to manipulate it, because they're like, okay, like the alignment's not quite right. And that might provide some relief, but temporarily, because like your elbow ultimately isn't straightening, but it did relieve some of the pressure from the joint, right? So there's some relief there. And then you're like, okay, well, the muscles really hurt, so I'm going to go to a massage therapist. And then the massage therapist will like work around the elbow joint, maybe on your shoulder, and like relieve some of that tension that's built up because those muscles are angry because they haven't been moving. And of course that'll feel good, but then it'll come right back because of course your elbow still isn't straightening. And so we think about like, well, I've tried a lot of things for my neck, right? But if we're trying to solve the elbow problem and we're doing all these things to the elbow, but we're actually not getting the elbow to move and straighten, then there's no reason for you to like be in a state of healing or restoration or find relief from the pain if your elbow is still bent, right? The problem is just going to come right back. You relieve the pain temporarily, but ultimately the underlying problem is not solved. And that's almost exactly what's happening in the neck. Like these joints are just not moving, and we've compensated. Our body's learned how to adapt, but ultimately, even with like acupuncture, dry needling, if we do chiropractic care, we do the manipulations to improve alignment, if we get an x-ray, if we do steroid injections, right? Everything is interacting with the neck in different ways. And we're shutting off pain, we're reducing inflammation, we're taking some stress off the joint, we're reducing muscle tension. But unless we actually get the neck moving the way it should, just like the elbow, the pain will come right back, okay? So this is the most overlooked cause of headaches and migraines, is dysfunction leading to restrictions in the neck and then also the jaw and the shoulders, okay? So there's obviously more complexity to this, but what I want to do on this podcast is simplify this, just shrink it down to the point that hopefully it's very understandable. And if this is like the first podcast you've heard, you probably have a bazillion questions, but hopefully this like clicks and makes sense for you, because what I want this podcast to do is motivate you to say, okay, like here's something real and objective that I can work on and fix, and will potentially provide me with the quality of life, the reduction of pain, the ability to not rely on medication or fear my next headache or migraine, and I can start living my life again. And that is what I got inspired by 10 years ago, and that is what I continue to do and what motivates me up until today and will continue to motivate me throughout my career. As I want to continue on this journey and on this mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. Please stay tuned, and I will see you all next week.